Hi, so today I am doing my individual reflection for the OB simulation. I just want to pull up my assignment to make sure I'm answering all the questions properly. Okay. So going into the simulation, I would say that I felt pretty well prepared. We actually had just recently had an exam in didactic on preeclampsia and a lot of your problems that can happen during labor. So I felt like I was kind of, well educated on possible outcomes, orders I may expect during the scenario. Sorry, my dog was at the door. Just kind of medications you can expect during the scenario, orders, kind of the state that the mother will be in. I don't have any clinical experience in OB, labor and delivery. I had one pediatric day, and then we had the one simulation day in lab where we did have a mother that was post-delivery that was hemorrhaging, but it is definitely a different situation. I would say that I wasn't really prepared for the way the simulation went. Like, it went a lot differently than I expected. In our original SBAR, our recommendations were way more geared to the idea that she would be going home on like certain medications and antibiotics. So it definitely went a lot different than I expected, but I think that is realistic, and that happens a lot of times when you have your patients. You can never count on it going a certain way. Okay, so the first question is to reflect on any ethical dilemmas uncovered during the scenario and describe how you might respond differently based on the situation. Provide evidence-based resources to support your response. So going through the scenario and then also just like kind of reviewing all my notes and all of the worksheets and stuff, I really couldn't like pinpoint a certain time that I thought the nurse, made the wrong decision or did something out of her scope of practice or performed an action that was unethical. She always was having like with the mag sulfate, she had it verified by another nurse. She was always in constant communication with the physician and the providers, always updating them on the condition, all of that. What was I else gonna? Actually, one thing I thought was that we would educate on like a lot of the procedure and like prepare her for that. But actually that was a question we got wrong because we don't educate on like anesthesia and the procedure. I've actually learned that through this scenario. And then we also just had a lot of our surgical education in complex health the past few days. So it actually, that was kind of something I didn't realize. That would be an ethical problem, is if we went beyond our scope of practice and we're teaching her about like the procedure and like anesthesia, because that is in that provider's scope of practice and not the nurses. We can kind of try to like support her, reduce her anxiety, answer certain questions, but we're not there to, provide an in-depth education on the procedure and to answer those very specific questions. So that was something I wasn't really aware of. I did kind of include in this section things I thought could have been done differently. They weren't ethical problems necessarily, but I do think they could have been done better. So my first thing was the education technique throughout the scenario. I do think that the nurse thoroughly like educated her before she would give a medication and everything, but I just think that she probably could have provided the education in a manner where then the patient was like repeating it back or verbalized more of an understanding. I think in the state she was in and the discomfort, you could tell she was kind of just saying yes to everything. I think it would have been kind of essential to make sure you have her have like more of a conversation with you, to make sure that she's actually understanding what you're teaching her and retaining the knowledge. Also, she just got like a new diagnosis of preeclampsia. She doesn't really seem to be too informed about what that means or what the disorder is as a whole. So I'm not sure if the nurse performed this education off camera, but I just think it would have been really essential to sit down with the client and educate her on what preeclampsia is, what that means for her and her baby, and just really go more in depth on it, because I know, like, I think a majority of patients would want to understand what's going on, and I don't really think she was given that opportunity. It was kind of an overwhelming situation where I felt like she was being told so much, and it probably would have been beneficial for like the nurse to just slow down a little bit and sit and help her out with that. I actually did some research on like my evidence-based resources for patient education, and I found that it's really essential in order to ensure that you're providing effective education to your patient. You first need to like determine your patient's learning style. So if this patient doesn't learn well through just verbal words, like she wasn't going to retain anything she was told, because she was given no like technological education, like she wasn't given anything on paper. She wasn't required to repeat back anything. So it really was just a nurse telling her stuff one time really quick while she's in such a state of discomfort that it's really unsure if she even remembered it. It's important to stimulate an interest with your patient. So, ask questions, get their emotions on it, their feedback, and their thoughts. So make sure that it's engaged not only for the nurse that's telling the instructions, but that your patient is engaged and actively learning. It can also be beneficial to use technology. I'm sure this patient had a television in her room, and I've even seen at my hospitals for clinical that they often will use, on top of their verbal education and their like handouts and stuff, they'll also can play videos on the TV in the room, and some patients learn really well through that, and then it's also there for them to go back and listen to. So she could have gotten like education on preeclampsia through that, and I think that education, like, instead of it being presented in an overwhelming way, it could actually have decreased her anxiety, because she would feel more informed about what was going on with her. It's also important to consider your patient's limits and strengths. I think that's really important with this this simulation with her condition, because she was obviously in great discomfort, and I think it's important to know that can like interfere with her education ability. So just understanding how important it is to get that feedback from her and having her repeat back what you told her, because she's in discomfort that she may just be saying yes to everything because she wants it to be quiet and she wants to rest. Like, she has a really bad headache. So it's just really, really important. Another thing is that you can include the family in your patient education, but there was no family present or any support in this scenario. And that kind of ties into my next problem I felt with it. My other major problem was that the nurse didn't ask at any point if the patient wanted her to call any support, any family, any friends. Again, I'm not sure if this was done off camera, but I think that in any setting like this, especially when they're in such a critical state, any state really, if they're in the hospital, it is vital to ask them if there's anyone they want you to contact to be there with them, because she is in a very critical condition. They didn't really have great control over the situation, and she's pregnant, so it could just be a baby she's having alone, but especially if that the other individuals involved in the situation, I'm sure they would want to be there with her, maybe even just some family or friends for support, because it's said that if you have, I read this on an AHA physician forum, that it's proven that having like patient supports present helps improve their hospital performance overall. It just increases the quality of care, safety, and the overall patient outcome, and it's a big thing that can help decrease anxiety as well. So I think as the nurse, when you notice that you're like the only support there for your patient, you want to make sure that you're asking if there's anyone that you can contact for them. And if there's not, that means like you are that support for that patient. So it's really essential to be there for them, show that you're being empathetic and supportive, allow them to voice their anxiety and their concerns to you, because they don't have anyone else there to do that for them. So I'm sure their anxiety's heightened and they're just nervous and scared, especially considering that this is her first baby and her first pregnancy, and she is pretty young, only 25 years old. So I'm sure there's a lot of anxiety going through her. So yeah, I thought that could be handled a little differently as well. Although it's not an ethical dilemma, it is something I think that as nurses we should be paying more attention to. Okay, so the next thing, let me read the question. The question was, okay. Describe an aha moment you experienced during this learning experience and how it expands my nursing care. I don't think I had like a major, huge aha moment. I think if I was kind of unsure that she had preeclampsia going through it, and then when she finally got that diagnosis, that would have been like my big aha moment. But it was named like preeclampsia simulation, so I knew like that was going to be the outcome and everything. I guess one of my big things, like I felt like I really knew what was going on, it made sense to me, was the magnesium sulfate medication order. We actually had predicted that we would likely get an order for magnesium sulfate in our recommendation in our original SBAR video. We just learned a lot about magnesium sulfate in our Women, Children, Family course, and just like the importance of it with preeclampsia and with preterm labor. So seeing that being used and being able to like accurately predict that order was kind of like made me feel like proud of my knowledge and my understanding of like the treatment and interventions we put in place for this condition. Another thing, I guess, when I think of AHA, I think of like something I'm like, oh my goodness, like I understand this, it makes sense to me, was the variable D cells. I know like I could be monitoring, like I've learned how to monitor for those and how to read the strip, and it was like kind of an overwhelming moment when they said there were those variable D cells, because I know how dangerous that is for the baby, but it was kind of like the dots lining up, and I was able to like understand where the scenario was going, and it was kind of like a big turn in events. So that was like another big aha moment. I think that those two experiences, like the diagnosis, like the medication and then the variable D cells, like the medication, it kind of shows me that I'm really like gaining knowledge about like medications and orders from the provider in the clinical setting. It allows me to feel kind of confident in my knowledge, but also reminds me always, though, you still have to be like checking your resources and double checking before administering any medication, and all of that. And then your variable D cells with clinical practice, it just shows you that like you constantly have to be monitoring that that external fetal monitor, and you have to be watching for any changes, because the variable D cells, they only occurred for 2 minutes. Like that's not very long, and then they went back to normal. So if for some reason like you weren't paying attention, and then you missed those, or you didn't like pay attention to the alert you got, you could have put like the mother and the baby in such critical danger. So it's so important as nurses to understand that like it's our responsibility and we're ensuring the safety of our patient and the baby. So we just have to be really on top of it, especially in these patients in such critical conditions where like anything's possible. We really have to be putting them first and knowing that even the slightest little change can indicate a big problem. But I have learned in clinical, like if that was to occur, a variable decel, like really randomly on a perfectly healthy mother, you are going to assess them and see what the cause is and make sure that your machine's not malfunctioning or anything, because I know like this patient is very like evidenced in the condition of the mother and like the declining condition of her. So that's kind of what supports your finding. But if it's in a perfectly healthy mother, you want to make sure that you're finding evidence to support that before just immediately assuming that like the 1 decel is like indication for like a C-section or something like that. Make sure like everything's placed properly on the mother, that they're not compressing anything, all of that. Okay, so the next question asks, what are some aspects of client care that you didn't feel prepared to make clinical decisions for in this scenario and or after completing your nursing care plan? Well, I guess once we first completed our nursing care plan in the beginning, I was a little anxious going in because we didn't have a lot of information on the patient. We had no prenatal history, no history on like her ultrasounds and stuff. I mean, we knew that this was her first baby. We knew her symptoms and such, but that was really it. It is kind of scary because you don't know what to expect going in, and you're kind of just making your care plan based on the knowledge you were given, which is, I mean, that is pretty realistic. That can happen in patient setting, and in the hospital you can get a patient that you don't have any history for them. You don't really know much what's going on except for their current state. So I know going in, our problems were her high blood pressure, her pain, the neurologic symptoms she was suffering. Well, not neurologic, but like the other symptoms such as headaches, the blurred vision, the nausea, vomiting, and the edema. So we wanted to get her into a point where her blood pressure was controlled, and also in addition to her blood pressure, that we were decreasing her edema. We were alleviating the excessive nausea and vomiting, getting her rehydrated, balancing those electrolytes, just decreasing her pain, getting her into more of a comfortable state. But again, like her coming in with all of this with no prenatal history, like you don't really know, did she have consistent prenatal visits? She might not have, considering that they typically would routinely check you for preeclampsia risks, and if you're developing preeclampsia at those prenatal visits, and she wasn't really informed about what the condition was or anything like that. So I think it could be a concern in her head that possibly she hasn't been having adequate prenatal care, because why wasn't she being screened for this? Why didn't they catch this earlier on before it was basically affecting her whole body? And like, why wasn't she informed that these symptoms are factors for preeclampsia? So that is a big concern and something we were kind of scared about. So during the scenario, some things that I didn't really feel prepared for. So something that kind of really surprised me and I didn't expect was that her condition really didn't didn't improve with all of the treatments that were being put in place. So at first, like, I know the nurse was doing her best with like the nursing interventions, and then she got the orders from the provider and she was implementing all of those orders. And I know that the blood pressure dropped for a little bit, for a short period of time, but her headache was still a level 8 on a scale of 0 to 10. She had lower quadrant pain when she came in, and it turned into a sharp right lower quadrant pain. She had epigastric pain, pedal and facial pain. Her edema in the face and hands never seemed to go down. She had cloudy vision, and then her labs were just not improving. Just like nothing was improving. Her general state of like malaise and everything, it wasn't getting better. And I just thought that with preeclampsia, she would come in, we would get orders from the provider, get her blood pressure under control, that a lot of the other symptoms would likely resolve themselves with her blood pressure being more under control. Kind of that she would get in a better state, and then she would have those precautions for the remainder of her pregnancy and be sent home on some like antihypertensives. But it definitely didn't go that way. I can assume that maybe it's because the condition was left go for too long, and it just was affecting too much of her body and had put too much strain on like the fetus. But I just wasn't really expecting that, especially since she was only at 27 weeks. She wasn't to term at all. So I thought that maybe there was something more we could do to kind of prevent her from going into preterm labor. But I think it was just too poorly managed throughout the pregnancy. And like I said, with no history, like who knows how long this condition has existed. So, and like they say that hypertension often goes asymptomatic for a while. So if she wasn't having those prenatal visits and she was asymptomatic hypertensive, she could have even been had hypertension before her pregnancy and not known. We don't have any history. We have no idea. So, who knows how long she's had this, and now all of a sudden she's in here with all these conditions because now it's starting to become symptomatic and affect her whole body. It's probably just really far along, and you want to preserve the health of that mother and the fetus to the best of our ability. So that's definitely something I wasn't expecting. Even when I look at my initial MPW, like my plans and stuff were not at all, even in my mind, the thought of like a C-section and all of that. Another thing I wasn't really expecting, the nurse was combining a lot of like non-pharmacological measures with her pharmacological. She was repositioning just like a lot of different things, and none of them were effective. Like I remember on her one SBAR call to the physician, or her one conversation, she said, like, listed off all the different therapeutic measures she had put in place, and like her and the doctor agreed, like, yeah, they just aren't helping. And I think again that ties into kind of what I just said, where she's just so far along in this condition that it might be just too late for these things to be working on her. And it's just something that I think I didn't think of before, that again, that she would be so far along that these measures aren't going to be effective on her. I just thought with the medication in combination with your non-pharmacological measures, like, would definitely help her and alleviate her discomfort, but her discomfort maintained throughout the entire scenario. You could tell even when she wasn't stating it that she was in obvious discomfort, obvious pain. She was just uncomfortable and did not feel well whatsoever. So I was a little surprised. I just think, I just assumed with that combination that it would work on that patient, but it is so important to remember that it doesn't work on everyone. Sometimes people are just too far along in their condition. Their body is too negatively affected. Another thing I wasn't prepared for, which I kind of touched on before, was just how her condition continuously got worse throughout her hospital stay. As I said a million times already, that I thought she was going to be able to be discharged, but even on pharmacological measures and everything, they were not able to get that blood pressure in a healthy range. They were not able to alleviate her other symptoms, and it got to the point where the fetus was now at risk. And this just really took me by surprise. I remember when I was going through this scenario and all of a sudden they were talking about a C-section and that they need to get the baby out, that I was shocked, honestly, because, again, I just hadn't seen it coming. But it definitely, it just shows me how you have to be prepared for all different outcomes. So maybe, like, even when a patient comes in, like, yeah, you're thinking about discharge from the beginning, but you need to think about, like, all the different routes that this scenario could take and be prepared for them, like, mentally and as well, like, in your nursing practice. Because if I had probably thought about it more, I could have seen, like, throughout her continuous assessment and everything that, like, she wasn't getting better initially, and her discomfort wasn't being alleviated, and that it most likely or could very likely turn into a more severe scenario, which it definitely did. Another thing I was surprised by, which I said was one of my aha moments, like I knew what it was and like I could understand the concepts and like why it was happening, but the variable D cells did surprise me because I knew that the mother was in like not doing well and that she was in a very like hypertensive state. She was at risk for seizures, and that everything that was going on in her body was obviously not good for that fetus. You know, her dehydration, her imbalanced electrolytes, the extreme hypertension, the risk for seizures, as I said, all of that. But I guess I just didn't really connect the dots in my head and throughout the scenario that, like, I knew we were doing external fetal monitoring, but I didn't really expect to see the variable D cells, and I didn't really expect, again, the C-section to occur. So when they said about the variable D cells, I immediately knew that that meant that baby wasn't doing good. I know that D cells are a big red flag. And like I have here, the baby's heart rate, we were monitoring, and it went like 140, 120, 124, 115, like it was decreasing. Like you can see that the baby is trending to decreasing heart rate, and then it went down into the 60s, which is like huge, like red flag, red alert. So I definitely wasn't prepared for that. But it just shows you, like, when the mother's not doing well, like, neither is that fetus, and your priority is to preserve both of their health. So that's why C-section was the best option here, is because they needed to get that baby out because it no longer was in a stable environment, and it was putting strain on the mother's body, and it was putting strain on the baby. So it definitely wasn't something I was expecting, but it made sense once it did occur, and I thought about it, like, this makes sense, what's happening here. And looking back on it, I think that's how I feel about the whole scenario and the way it progressed. Like, when I think back on it and I re-look through everything, like, it really does make sense the way the events played out. And my last thing was just kind of like something I didn't expect was just kind of her decreased level of consciousness. I feel like, yes, she was conscious, but almost like, decreased level of consciousness in the way where, like, she wasn't as responsive, she wasn't very engaged. I kind of touched on that in the education aspect where she was just saying yes to everything. She just was so tired. She didn't really want to talk. All of that. I guess I didn't expect that with that condition. Like, I thought she would be kind of in her normal mental state, like able to learn and like hold conversations, but she really didn't do much of that until right before the surgery. So I think it's important to remember in conditions like this where it's affecting their whole body and the strain it's putting on her body, that obviously it's going to make her just exhausted. It makes it, with her discomfort and that exhaustion combined, it's harder to listen and just learn and focus because all you can think about is like the pain you're in and like how tired you are. And, you know, it's already exhausting for women that are carrying children in addition to having such a critical health condition going on. I just wasn't expecting that, and it definitely challenges you and challenges me as a nurse, like, you have to really figure out ways to engage that patient and educate them and make sure that they're okay. And you want to make sure like it's not just that they're like, you want to be able to determine that this is just because they're exhausted. You want to make sure that there's nothing else going on there that's kind of putting her in this state of like not being very responsive and stuff. So that was something I definitely wasn't expecting going into this, and made the scenario a little bit more challenging, I thought. Okay, so the last question, it says to describe 3 to 5 important concepts I learned from this scenario, and then describe how I will apply this knowledge of each concept to future client situations. Provide evidence-based resources to support your response. Okay, so I actually do have 5 things that I learned from this scenario. So my first thing was the importance of the non-pharmacological measures with the medications. As I said before, I know they weren't very effective in this scenario, but it just shows you, like, obviously in something so severe like preeclampsia that was probably left untreated for a while, you would think like you're obviously thinking right away like the pharmacological measures, magnesium sulfate, the antihypertensives, replenishing those fluid and electrolytes due to all like the nausea and vomiting. But it's so important as nurses that we're always using our nursing interventions and our therapeutic measures in addition to these orders by the provider. This can just really help, decrease the fear in our patient and the anxiety, increase their comfort, and like even increase the effectiveness of our pharmacological measures. So I know that even though they weren't really effective in this scenario, she was always trying to provide comfort to that patient with positioning, the oxygenation, allowing her to rest, the NPO, like all of that was just kind of ways to try to increase, like help her condition outside of the medication. I do think like she probably decreased her anxiety a little bit with like the allowing her to rest, obviously being supportive, like watching her with the medication and all of that. So although it wasn't effective in this scenario, it is definitely a benefit, and who knows, her condition could have been worse without the non-pharmacological measures. We just aren't really sure because we didn't get to see a scenario without them. So those are always just so important, and it just kind of reminded me of how important that is for every single patient to always be remembering that we have to include that in their care. So my second thing I learned was preeclampsia's effect on the entire body. So obviously I know through like my didactic learning the effects of preeclampsia, and honestly like hypertension as a whole, I know that it can go asymptomatic for a while, and then by the time you notice it's usually affected a majority of your body. But I kind of think like, I don't know why, I just didn't really put the two pieces together for preeclampsia, just because I think I kind of assume that you usually catch it earlier on at your prenatal visits. But obviously in this patient, it was affecting her whole body. She was nauseous and vomiting to an excessive amount to the point where her body had fluid and electrolyte imbalance. She had blurry vision. She had a severe headache. She had pain, epigastric pain, right lower quadrant pain. It was really affecting her whole body and her ability to function and perform activities of daily living. So, I read up actually on it on the U.S. National Library of Medicine, an article that's kind of describes it as like a package medication that can affect the whole body, and it can affect a lot of your organ systems. And that's kind of what I think we saw here in this patient. And it's just so important with this to always make sure that prevention is your number one key. So I think that's kind of like my big takeaway from this is with this patient, like the prevention wasn't key in her care. We're unaware if she had that proper prenatal care or anything like that. but it's so important to make sure with your pregnant women that they know the importance of prenatal care even before they get pregnant, that they're going somewhere and getting the proper screenings, that they're aware of the signs and symptoms of preeclampsia so they can catch it early on before it can develop into something like this. It's just really important throughout the entire pregnancy to be continuously educating them, screening them, and just preventing that. And that's like my big takeaway for my nursing care. So many conditions, it's all about prevention, but especially this one, because we got to see in this scenario just the negative effect it can have if you let it drag out. So yeah, it's just really important to understand the negative consequences of it and how important it is as nurses that we're preventing it. So another thing I learned is preeclampsia and placental abruption. So this just isn't really something that crossed my mind since the preeclampsia was, occurring for probably an extended period of time. It has had so much effect that not only it's affecting the mother, which is evidenced by all of her symptoms, but it's obviously affecting the baby as well, which is evidenced by its variable D cells. So before, when the provider came in and discussed with her about a C-section because they suspected that the placenta was coming, disattaching from the uterus most likely by the variable D cells, and just how the condition was worsening and wasn't getting any better. I read up on it on Mayo Clinic about just preeclampsia and placental abruption. It just puts the mother at such risk of like heavy bleeding, which not only puts the mother at risk, but also the baby. And also it has to do with that HELP syndrome, which is that progression of preeclampsia. It's when they have the elevated liver enzymes, which actually she had, the AST was 75. It was very elevated. You have all of this stuff going on with this HELP syndrome, which is totally lines up with what this patient was experiencing. So it is so important as nurses to know like the complications of the disorder you're dealing with, because as I said when I went in, I just wasn't expecting it to take such like a drastic turn. But if I had kind of refreshed myself on the complications of the disease before, like I probably would have been more aware and more prepared for what was coming. So yeah, it is a major complication, and once you are starting to see those risk factors pop up for it, you can kind of catch it before it fully occurs, because she wasn't experiencing any hemorrhaging yet. She wasn't at that point. They were actually able to catch it before that occurred. And that helps, preserve the safety of that baby and that mother, because yes, the baby is still going to be at risk being so preterm, but they have a lot better of a chance of survival than if the mother started hemorrhaging and the placenta became completely abrupted. So that definitely teaches me for future nursing practice, just always to make sure I know the possible complications of what I'm dealing with and kind of like the risk signs of it and early signs, to make sure that I'm providing the best possible care for my patient and preventing any complications and catching them early on to the best of my ability. Another thing that I learned, I was actually kind of surprised by, was the bed rest order by the provider. For some reason, what stuck in my head most from didactic was like that strict bed rest isn't really evidence-based for pregnant women or like preterm women, but the difference here is her condition and like the external field monitoring and all of that. So I actually read an article by the Preeclampsia Foundation, and it just talks about how, yes, like strict bed rest isn't evidence-based and isn't necessarily beneficial for like a stable mother with preeclampsia, but due to the fact that our patient had problems with the placenta, she was having the, her condition was very unstable, the baby's condition wasn't stable, she's at risk for this bleeding problem, for hemorrhaging due to the placenta, that she is very, very qualified for strict bed rest, and it is beneficial in her case because if she's constantly ambulating, that's putting more strain on her body and on the baby as well, and also she's on the external fetal monitoring. So that's definitely something I learned from that, is that you just have to know like what qualifies them for the orders. Obviously, if you get an order for strict bed rest, it doesn't hurt to like make sure you look it up and research like if her condition is one of the qualifiers for it, because you don't want to always just think like, oh, if the provider ordered it, like then it's definitely something that's safe for this patient. It doesn't hurt to double check, but in this scenario with double checking, I was able to see through the Preeclampsia Foundation that her criteria was one that required strict bed rest. But if she was stable or just at risk for preterm, they would never recommend strict bed rest. Obviously, you want to balance your activity and your rest, but you don't want to just be in bed all the time. And the last thing I think I learned was just the use of lactated ringers. I really hadn't heard that name before. I don't know why. I just don't think I've heard it much in didactic or clinical. I've just always heard, sodium chloride. So that was kind of a new medication for me. I was able to, identify that due to how severe the preeclampsia was, she was having that excessive nausea and vomiting, which then had the effect where it was causing a fluid and electrolyte imbalance in our patient. So the lactated ringers were able to restore that fluid and electrolyte balance, which kind of just helps decrease her nausea and vomiting a little bit. It can try to help, decrease that headache, help a little bit with balancing the blood pressure, which it may have done a little bit in this patient, but again, her condition was just very severe that we weren't really able to get it under control. But yeah, I was able to read up on that and drugs.org and just find out more about lactated ringers, kind of update my knowledge on that. So now I know in the clinical setting, if I ever get an order for that, I will be aware of what it's for and the purpose of it. So yeah, it just kind of adds to my clinical knowledge and my ability to read orders and understand them. So yeah, that's all of the questions that I had from the simulation. I do feel like we handled it pretty well. We did make a problem in our decision making at the end. I remember about educating about anesthesia, which is kind of like what I talked about earlier. Something I wasn't expecting was just how what we educate and what we don't. It kind of helped me understand through that and the recent classes I've had lately about surgery that that's definitely in the scope of practice of your provider and your surgeon, and you're just helping to be supporting, answer some questions, decrease anxiety. We answered a question wrong though about that at the end, and it ended our simulation early, so we actually went back through and just watched to make sure that we weren't missing out on any part of the delivery or anything. But it really didn't change anything at all. It was exactly the same. But overall, I felt the simulation was really beneficial to me educationally, because I had learned so much about preeclampsia in didactic, but I never was able to really apply that knowledge to an actual scenario or even experience it in clinical. So it was helpful to learn more about the condition and also the multiple outcomes that it has. So yeah, that's all. Thank you.